Okay, okay. So let's talking about a little about the liquid biopsy. So we can see that in the adjuvant chemotherapy, in the adjuvant therapy setting, right now we have several strong evidence, to support we using the liquid biopsy, the ctDNA, using for the decision making to decide which patients should receive the adjuvant immunotherapy with all this data and the in vigor or 1-1 and also with the codex the data from the checkmate 274. And so I want to ask, do you routinely use the ctDNA right now to guide your adjuvant therapy or adjuvant immunotherapy in your clinical practice right now?
Um, I mean, I haven't, but I think with the IMvigor11 and 274 data presented at ESMO, I think I
Mhm.
will. To me,
Okay.
the most compelling is, those negative patients do
Mhm.
really well.
Yeah.
Their
Mhm.
recurrence is low, their survival is great, so it's really
Yeah.
hard to justify
Mhm.
giving those patients adjuvant immune therapy. The chance
Yeah.
of them benefiting, it's hard to
Sure.
benefit when 9 out of 10 people aren't going to have recurrence anyway, right? So
Sure.
I
Mm.
think I think those patients, can safely be observed, and then
Okay.
obviously treated with whatever if they are the rare
Sure.
patient who has recurrence.
Mhm.
Um, and similarly, on the other side, I think, the positive patients obviously have a much higher risk of recurrence. And so in any adjuvant setting, you want to enrich for patients who benefit. And in
Mhm.
this case, it's a prognostic marker. So if you are ctDNA after surgery, or I guess within a year after surgery, according to IMvigor11, then you're obviously at much higher risk of recurrence, and intervening in those patients can show a difference. Again,
Yeah.
it's just the
Okay.
unique nature of the adjuvant setting where some patients will never have recurrence. You can't possibly benefit
Okay.
those patients by treating them. You can
Yeah.
only harm them. So,
Yeah.
so yeah, I think that's going to be pretty
Mhm.
routine. Having said
Okay.
that, again, we don't know how to incorporate that with neoadjuvant EV pembro. So if you get
Okay.
neoadjuvant EV pembro and cystectomy, and then you're ctDNA
Mm.
negative, does it mean you don't need more therapy? Again, that's not how the trial was done. But you
No.
can envision some people doing that. I'm not saying it's right,
Sure.
but you can absolutely envision
Yeah,
people
yeah,
saying,
sure. In
well,
the real world. Yeah.
yeah, and I don't, you know, I don't, again, I don't know that there'll be a randomized trial, but
Mm-hmm.
you can imagine a cohort of patients who get neoadjuvant therapy, don't
Mm-hmm.
get the adjuvant portion, who are ctDNA negative. If you
Mm-hmm.
follow those patients and
Mm-hmm.
they do really, really well, boy,
Mm-hmm.
it's hard to argue that they should have gotten
Yeah.
therapy. Again, I don't know that
Yeah,
we'll
yeah.
ever have a definitive answer to that, but I think data sets will start coming out of,
Mm-hmm.
people who do that and keep track, single arm cohorts, things like that.
Okay. So the next question is that what is your preferred interval and also the frequency for the ctDNA testing when you during your decision
Yeah,
making
I
for
don't
the
I don't
adjuvant
know that I have an
immunotherapy?
established pattern. I think probably,
Mm.
checking it with each CT scan makes sense to me. Like every
Okay.
3 months,
Mm.
I'd probably do scans
three
every three
months.
months in the
Okay.
first year after
No, not
cystectomy.
according to the InVigor
No,
one
doing it
or
every
first
six
go, no.
weeks, and I mean, that's a pretty big
Hmm.
burden. I'm not sure that
Yeah.
there's the advantage of getting it every 6 weeks versus 12 weeks.
Hmm.
You'd be hard pressed to convince me
It's
that,
very
first of all,
costly.
I don't think that it was a relatively small percentage of patients that turned
Hmm.
positive in that year, right? I don't
Hmm.
remember the number.
Yeah.
And so
It's
starting their
a, it's a
therapy
very
6 weeks
small
later,
proportion. Yeah. Mm-hmm.
you'd be hard pressed to convince me that a delay of therapy of 6 weeks really impacted outcome.
Okay.
It's not really
Yeah.
believable. So
Yeah, I agree
this
with
is
you.
just, many patients at our center, and I'm sure at your center, travel a couple hours to see us. So to make them come back and forth or get a blood test
Mm-hmm.
every 6 weeks versus I would probably just do it when I see them for scans.
Not so practical.
Yeah, I would tend to be more practical about it. Yeah.
Okay. So another more, I think, more technically issue or the question is that how do you define and interpret the ctDNA abundance? It remains, to be there's a lack of the standard when there is abundance or standard. We can see that you have a positive ctDNA because right now the technique is different and also it's very different from US and also here in China. And we also there are different technology. We use the VAF or there are several companies or several techniques we use the cancer cell fraction. And so Is there a standard or what's your preferred, for the interpret for the ctDNA results?
Yeah, I mean, I think I would just stick to the Signatera definition from InVigor 11. I think they had
Hmm.
to have
Okay.
two out of,
Okay.
I think it's 16 mutations. I don't quite remember the denominator
Mm-hmm.
of how many mutations they test for, but
Yeah.
yeah, I don't have a
Mhm.
different definition. Again,
Okay.
I tend to stick to the data from the clinical trial, so I'd probably use that
Okay.
definition.
Okay. So it remains a no. So we can maybe there leaves us as a lot of work to do, to build or set a standard for the clinical practice, I think.
Yeah. Yeah, and I think, I don't know that different definitions would be that important, and I think that's the
Mm-hmm.
nice thing about ctDNA is there's not a lot of interpretation. I
Mm-hmm.
do work in kidney cancer and RNA gene expression. That's much more
Mm-hmm.
complicated. And,
Yeah,
what
sure.
is this group or that group? That's much more complicated.
Mm.
This is pretty
Yeah.
binary. Like it's
Mm-hmm.
either detectable or it's not.
Sure.
I haven't heard a lot of discrepancy about patients who are sort of positive
Yeah.
or
Yeah.
false positives or anything like that. I
Mm-hmm.
don't think that
Mm-hmm.
exists to any great extent.
Yeah, but also there is a limit, to detect the ctDNA when it is
Sure.
low than the limit, but the limit seems to be, to be could be changed, it's rely on the different technology, and also it may be
Yep.
different from centers to centers.
Sure. Yeah, I think there's some variability. I've not heard a lot
Mm-hmm.
of, uh, you know, noise around that being a big issue,
Mm-hmm.
though.
Mm-hmm.
I think it's pretty well established and pretty
Mm-hmm.
binary in terms of you're either positive or not. And
Mm-hmm.
I've not in practice, although I've not used it a ton yet, run into patients where the test is ambiguous or this. And
Mm-hmm.
so, I don't think that's going to be the issue. I don't think the test itself
Okay.
will be the issue.
Okay.
And, I suppose as we develop more sensitive
Mm-hmm.
ctDNA tests,
Mm-hmm.
I guess you could ask the question, well, is any bit of ctDNA detectable the same,
Okay.
Because right
Mm-hmm.
now we have a
Okay.
certain threshold.
Yeah.
If we lower that
Mm-hmm.
threshold and can detect smaller and
Sure.
smaller amounts,
Sure.
is that the
Mm-hmm.
same biology?
Mm-hmm.
Is it just yes, recurrence for those patients and no or not? Or if you're detecting super minute fractions, are those patients really at risk? I suppose that'll be an area what we sort of get into as these tests become more sensitive, presumably.
Sure.
I'm not sure that's the most important area of research for ctDNA. I think how do we apply it in clinical practice? What do we do if you're negative
Yeah.
after
Yeah.
neoadjuvant EVP? What do you do
Yeah.
if you're negative after neoadjuvant EVP before cystectomy,
Mm-hmm.
right? Like,
Yeah.
that's a big
It's a
area
very
is can
interesting
we avoid
question. Yeah.
cystectomy in a subset of patients?
Sure.
And again, there's no data, there's no randomized data. Certainly, there's some
Mm-hmm.
single arm data that Matt Galsky published a couple years ago. So
Mm.
I think we're about to enter a really interesting period where ctDNA will be part of, integration in these patients.
Yeah. Yeah.
I'm not sure the more sensitive ctDNA is that important, but I don't know. I hadn't
Mm.
really thought about it, but I think it'll be part of the picture for sure.